select. So he's going to tell us about how to select patient for transplantation in ACLF. Thank you very much, Professor Rela.
Thank you. I was looking for answers from the hepatologists as to when to do transplants for ACLF. I think today we have some of the most powerful people, really. Rajiv Jalan, John O'Grady, Professor Patrick Campbell, Jules on the other side, really, to tell us. I won't go into the definition. Obviously, there is a East and a West definition, which again made me very skeptical when it came to liver transplantation for ACLF, because when you look at the Eastern countries, most of them were actually reactivation of hepatitis B, where the reversibility is very clearly noticed, and I didn't believe that the outcome of this can be equated. Now, this is what you saw again from Rajiv Jalan's paper, which convinced me, first of all, about the diagnosis or acceptance of it, because in the type A and the type B, it was easy for me to accept the definition of ACLF with the reversibility, but in the type C, I've always thought that it was actually natural history, where the likelihood of reversibility is probably negligible. And I just want to read one statement from his paper, which really somewhat convinced me. An intriguing and important finding was that patients without prior hepatic decompensation had higher short-term mortality than patients with prior hepatic decompensation had a higher short-term mortality than patients with prior hepatic decompensation. That supports the position that ACLF can be distinguished from decompensated cirrhosis. Now, we know that, I want to just anecdotally talk about something. Professor Williams is there. We've all got our own incidences, and there are patients which stick to our mind, and it takes a long time for us to remove that as the clinical situation that comes to our mind. I think probably Jules will remember, there was a patient called Lockhart, I think was his surname, maybe Graham Lockhart. He was transplanted for ACLF. Nigel will remember him as well. And we probably spent close to 500,000 those days. This is 20 years ago, when we did not transplant patients with ACLF. I'm pretty sure we transplanted that gentleman because Professor Williams told us all that he's an awfully nice English gentleman. That used to be one of the criteria for transplanting people. And he did survive, but he cost the NHS a lot of money. So you did save his life, but it did make an impression in my mind that I'm not going to be transplanting patients like this, because he was in ICU for more than 3 months, wasting away. And it's really the good ICU care which really made him survive. Pardon?
It wasn't good enough. The surgery was okay, but...
You're absolutely right, because ACLF has become an indication for transplant because of mainly intensive care management. So probably we were not so good those days with looking after these patients and taking them through. So it's very clear, really, the survival for ACLF. If you look at the Eastern and Western centers, we are getting almost 1-year survivals of 75, 80%, and even 90% in the Eastern centers with hepatitis B as the etiology. And 5-year survivals are acceptable. So I'm not here to say transplantation is not indicated. It is definitely indicated. And if you look at the East and West is there, and if you look at people from Korea, they have done dual grafts, right lobes, left lobes, with 5-year survivals of 70% in comparison to 80% for non-ACLF patients. But this is the worry I have, that the hepatologists need to tell us who are the patients who are not going to be needing transplantation. And this is a statement which says ACLF is an extraordinarily dynamic syndrome with a resolution observed in 42% of the patients, indicating the reversibility of this condition, and actually putting a caution into my mind that you cannot transplant all patients with ACLF. So who are these? And these are the lessons learned really from acute liver failure, but that this group of patients will survive and they shouldn't be transplanted. And the time to make that decision obviously is before that patients are going to die, and there has been some there is a lot of literature on really assessing them in the first 3 to 5 days before you make these decisions. Now this, I don't know if this abstract has become actually a paper. I've not, people who may know about this might tell us that this has actually become a paper, where there is one end which says bilirubin of 20 milligrams, creatinine of less than 1, INR of less than 2, MELD score of less than 27 is associated with 100% survival. So maybe I can choose that as a criteria to say if it fulfills this, I shouldn't transplant them. On the other hand, you've got the other extreme. There must be something in between, the large group of patients where we are not able to make a decision. So a MELD of, bilirubin of greater than 22, grade 3 encephalopathy or grade 4 encephalopathy, IN of 2.5, 100% mortality within 28 days. And in that group of patients, obviously there will be patients who've got futility as well. So I've been looking really at the timing of liver transplant for these patients in order to avoid patients who might get potentially transplanted, who shouldn't be transplanted. And here in the canonic study, the 90-day mortality reached 100% only in patients with ACLF3 and greater than 4, or the ACLF score of greater than 64 at 3 to 7 days after ACLF diagnosis. So are these the patients you should be looking at transplantation? Now, I think the simple way I look at it is really to look at organ failure, and this really, without going into too much details, gives you an idea of who's going to survive and who's not going to survive. So more than 2 organ failure associated with ACLF. You have to remember, these are all patients with cirrhosis. And one needs to not just look at 30-day survival. You should also be looking at 6-month survival, 180-day survival. There is no point in thinking that I've got through their acute insult and therefore these are patients who are not. This is the problem I have with the reversibility. The reversibility in acute on chronic liver failure is the temporary reversibility. So we need to know what's going to happen to them, whether they're going to be readmitted with sepsis in the next 3 months or 6 months, and then will die of it. So 180-day mortality is actually more relevant for patients with ACLF than the immediate reversibility and discharge from hospital. So that is another thing really which is confusing. So it's very clear really, ACLF1, ACLF3 and 4, 2 organ failure, 3 organ failure. You do a transplant, you can immediately really improve their survival. So this is the group of patients who are not going to survive 3 and 4. Transplanted, you push them up into 1 and 2. But so it's easy for me to offer transplantation for patients with 2 organ and 3 organ failure. But I'm only worried about with patients with no organ failure or patients with 1 organ failure who have got 180-day survival of 50% and 60%. Who is this in this group of patients that we need to be transplanting is my worry in this. I think we need to look at this. I think I've looked at this chart many times in trying to understand it. You look at ACLF1. Sorry. I don't have many more slides. I just probably will talk about this. You look at ACLF1, 202 patients, 90 days transplant-free mortality. His number is 172 out of 202. I would say all of them need a transplant. The risk of death is so huge. These are not acute liver failure patients, that they're going to be completely normal with a fully regenerated liver at the end of it. And many of them, and this is only 90 days, I want to know what 180 days is. It's only a very small group of patients in this ACLF1, which is really out of 110 patients, you're going to have a 20% survival really in this group of patients. So how are we going to separate out this patient, this number of patients, which is 19 out of that 202, to prevent mortality for the remaining 172 patients is a question that I want to ask the hepatologists. Even in ACLF1, it's easy for me for ACLF2 and ACLF3 to offer transplantation. Here you see, it's not that different for ACLF2 as well. 136 patients with a 90-day mortality of 110. you're inclined to offer all of them transplantation. And here, 50 patients with a 90-day mortality of 45 patients. So if I actually look at only this chart, and if I was to get overall survival for the whole group of patients, I really need to transplant all of them in order to get a good outcome for this. And this chart, this table is not giving me any clue as to who not to transplant unless the hepatologists are going to define only this group of patients for me, and in ACLF2, this group of patients for me who've got less than 20% survival. Unless you define those, who they are, who are going to survive, it's very difficult for us to be really separating out who should be transplanted and who should not be transplanted. And there are algorithms really which doesn't really fit in both by the Eastern group as well as the Western group. And it's interesting that what I've been saying, and if you look at this EASL study, 2015, all of them, ACLF1, no ACLF, ACLF grade 2, ACLF grade 3, you find that they're putting all of them through assessment for liver transplantation. So is that the message for us, that any patient who's diagnosed to have ACLF with underlying liver disease, who's got acute decompensation, should be considered for liver transplantation? I think I'll open that for discussion for the hepatologist to tell us who we should not transplant in the whole group of ACLF patients. Thank you very much. The questions are not going to be to me. It's going to be Professor Rajiv Jalan, Dr. O'Grady, Dr. Patrick Carmichael, Professor Williams, and Dr. Wengan. Can you come up?
Mohammed, that's very provocative. It's also very pertinent because I think you've touched on a lot of the issues in relation to transplantation for this entity, if the entity exists. I'm with Patrick Kamath. I have yet to recognise the God that tells me what this condition is. And until we get there, we really have to be incredibly careful. If we get there, however, a lot of the issues that you raised are worth discussing. Firstly, what do we mean by transplant intervention? Is transplant intervention, in your situation, of planned lifelong care with donation of an organ from a living donor? You could argue that this severity of this decompensation with this event is an indicator that this patient is in a high-risk group. And you could argue that these patients should be going on to a formal assessment for transplantation. If, however, you're delivering...
But then we shouldn't be using... Okay, all right, sorry.
Can I give you the counterbalance, please? If you are, however, in a Western system, which is using a limited resource in a competitive way, and then there's the additional argument about giving these patients prioritized access to transplantation, you have to assess it in a completely different conceptual way. And until you get to agreed definition, agreed prognostication, and a much, much better understanding of this condition, then it is going to be difficult to develop the argument about liver transplantation in itself, and particularly prioritized access to transplantation.